We are meeting again today. Yesterday we met to discuss issues that impair our intake and also our absorption at large. We have been looking at a different number of things from the when we started when we were introducing clinical nutrition to the interventions, a few things to do with what malnutrition is, things to do with what overnutrition is in terms of the overweight and obesity. We've seen a few things here and there in some smaller brackets of micronutrient deficiencies. We also found a way of how to assess the nutritional status, the demispan, the BMI. Then we looked at the different assessment methods, the dietary assessment, the clinical assessment, the laboratory, or what you call biochemical assessment. And also we looked at propometry, where we are looking at taking the physical measurements. We've seen quite a number of things, and we've also seen some interventions here and there from the enterals to the parenteral to the oral nutrition feeding, all the tube feeding information we've been seeing. We've seen some ways in which we can use nutrition to try and deliver some support to people suffering with the various metabolic conditions or conditions that are composed in the metabolic syndrome, the hypertensions, the diabetes, etc. And so today we are looking at intake like we looked at yesterday. Yesterday mostly about the gastrointestinal disorders. We were looking at mainly the mouth and the esophagus. But today we are going to interest ourselves and look at what happens downwards when we are going into the stomach. So friends, I hope what we've covered is really a lot. If you've been taking part in it, you can really see that there is a lot, and I understand this is the little challenges for you to cope up and all those things, but what I beg us is to try as much as possible to do our work on our side, because I know at the end of the day it will be us facing those clients out there, and it is this knowledge that you get at the end of the day that will help you outcompete your fellow dietitians or your fellow nutritionists at large. So today we are looking at ulcerative colitis, also which is a chronic inflammatory bowel disease that usually affects the lining of the colon, or what you call the large intestine. Could be leading to the symptoms such as the abdominal pains, the rectal bleeding, the weight loss, and we are saying really the cause is an intestinal allergy and possibly triggered by certain foods such as the milk. Also, we are saying the symptoms of this ulcerative colitis, or you could call it colitis, it depends on your pronunciation and which school. Some of us went to rural schools in our elementary school, and sometimes these pronunciations play us. But really, to take away, we are saying a person suffering from ulcerative colitis will come presenting with loose stool and with mucus and blood, and also they will come and tell you of the abdominal pain. They will come and tell you of the rectal bleeding. They will come and tell you of the fever, and also they will tell you of the dehydration and the electrolyte imbalance. And at the end, we will talk of the malnutrition that will happen therein. And really, this in term of treatment, mostly we need to think of ways on how to regulate or reduce the inflammation and also manage these symptoms. For things like fever, we find ways of managing. For things like dehydration, still we find ways of managing. And the electrolyte imbalance, we know those electrolytes that are really required. Then for the nutrition implication, what happens if you have ulcerative colitis at the end of the day? You will get anemia. There will also be increased nutrient needs and a fluid imbalance. And also we talk of the food maldigestion and nutrient malabsorption. So when we are talking of nutrition, we are not only talking about intake, like you've seen from where we started from. However much a person is able to eat, however much a person is getting all the foods that have the best nutrients you could ever think of, all the foods in their recommended portions. Really, that doesn't entirely mean that this person is going to be well nourished at the end of the day if there is impaired absorption. And this impaired absorption, we are thinking or we are seeing that most of the challenges that happen are within the gastrointestinal system. Also, what are the aims of the nutrition management? So, when you manage nutritionally, what are you trying to do? You're trying to relieve pain and inflammation, okay? And also, you're trying to restore and maintain the optimal nutritional status. And you remember what our optimal nutrition status was. I hope you remember the 18.5 to 25.9. I hope you remember that that's where a person with a normal BMI falls if you're using BMI to categorize their nutritional status. So we are talking of the dietary management for ulcerative colitis. For people who were with us yesterday, can really remember that when we talked of the Crohn's disease, we are talking of a disease of inflammation that happens from the start of the alimentary canal to the end. That is where we are talking of from the mouth to the anus. And we are saying dietary interventions seem to lessen the disease activity. Okay, yeah. However much you're trying, but when the disease is there, it's not that you're going to only rely on nutrition. Okay, you're going to also rely on those anti-inflammatory drugs and also all those other things. When you're saying unlike Crohn's disease, remove of the colon and rectum cures the ulcerative colitis. We talked about the Crohn's disease, that this is an autoimmune disease. Okay, I hope we all remember at the end of the day. And when we talked of an autoimmune disease, we said that an autoimmune disease is that disease that sorry, when we talked of an autoimmune disease, we say that that is a disease whereby the body fails to recognize itself. Though some history has argued that really it is majorly to do with the inflammations, and like ulcerative colitis, the Crohn's disease also tends to have those periods of flare-ups and remission. Okay, and so still treatment will include those things, and sometimes surgery to remove that portion that is damaged, that portion of the intestine that is damaged. All right, so friends, let's switch and look at another disease or another term really here in these disorders, the gastrointestinal disorders. We have the diverticular disease, though some people have called it the diverticulitis. We are saying this is a condition that is characterized by inflammation as the other things, and we are saying, oh, there could be infection of the small pouches, which people term as the diverticula, and these develop on the walls of the colon. Okay, yeah, and we are saying this can form when there are. We are saying this can form when there are weak spots in the colon's muscular walls, so that then the colon starts to bulge outward. And what we are saying that the cause is the increased pressure on the intestinal lumen. When we talk of lumen, we are talking of that gap, okay, where the food passes, that pathway or that hollow pathway where the food passes, and we are saying the chronic constipation can cause this, and also diets that are low in fiber. So diverticular disease or diverticulitis really affects a lot those people who are aging, who are a little bit old, and also those who are having low fiber diets. I hope when we talk of fiber, we know those foods that are rich in fiber. And also we are talking of gross bleeding. Is someone trying to communicate? Okay, and also we are talking of low hemoglobin and albumin levels, and also ulceration or perforations of the lower intestines. We talked of dysphagia, where we are talking of when someone does not really want any intake, and also sometimes which could be resulting into vomiting. I hope you remember all these. Okay, where someone is having problems in swallowing, and we said this can occur at any point along the swallowing process. After the chewing of the food, then the food, someone is having problems with moving the food down the esophagus into the stomach. We talked about those things, the issues with the stroke, the muscular disorders, and also the structural abnormalities when we're talking about dysphagia. And also, still, we appreciate that cramping is also an issue. Okay, yeah. Cramping, here we are looking at those involuntary muscle contractions, okay, that sometimes usually cause that pain or that discomfort, and these can occur at the different or various parts of the body, including the abdomen. In most cases, this is what the women usually get during what they term as the menstrual cramps, and also gastrointestinal issues such as the gas and diarrhea. And these we will see later on in more serious conditions like the appendicitis that such issues happen. So really, it is good to understand what happens. Okay, what happens when you have the diverticulitis, so that if a person comes presenting with these signs and symptoms, if someone comes and tells you of them having the cramping, if someone comes and tells you of the abdominal pain, and really you're seeing that their diets are low in fiber and all those things, really someone you can, using your knowledge of nutrition, you can really know that this is what this person is suffering from, and how you will see how you can counteract that. And with the diverticular disease still continuing, we are looking at the alternating between diarrhea and constipation. In most cases, when we talk of the alternating means you could have diarrhea episodes. Then at the end of the day, still you will have the constipation, though rarely do they walk hand in hand when it comes to nutrition. In most cases, what we have, it is the diarrhea for the underweight, and then the constipation could come for the people who are overweight, because now the food is taking very little, it is taking a longer time, excuse me, to walk through the entire alimentary canal. So that means a number of nutrients are being absorbed, and when the nutrients are being absorbed in bulk or in large quantities, then we'll see overnutrition setting in, and then the obesity there. So when we talk of regurgitation, I hope we understand when we talk of regurgitation, and also the bad breath, and also we talk of the low grade fever. Really, these are very easy signs and symptoms. Many people regurgitation could be the issue here, and we are saying this is a backward flow of food contents. Okay, when someone as if tries to vomit, and we are saying unlike this vomiting, which has that forceful expulsion of the stomach contents, with regurgitation, really it is not you're not feeling the pressure coming from the stomach. Okay, this regurgitation is more in a passive way, and people usually do it if they want to lose weight. They find ways of regurgitating the food so that it comes back, so that they reduce on their so that they do reduce on their weight and those things. You remember when we were looking at the anorexia nervosa in those earlier lectures that we had. For the nutrition implication and the aims of nutrition management, we have anemia, and I think we've not yet done anemia, but we will do anemia on its own because it is really big. When we talk of anemia, we're not talking of only iron deficiency anemia. There is megaloblastic anemia, plastic anemia, and all those other types of anemia as they win. But yeah, really, when we talk of anemia, in most cases, our minds have to look at hemoglobin, and we are referring to the IDA, which is the iron deficiency anemia. We will look at the increased nutrient needs and also aims. In aiming, we're trying as much as possible to restore the nutritional status. If this person developed diverticulitis when they had a normal nutritional status, we are trying as much as possible to bring them back to this normal nutritional status, and also to relieve the pain and also enhance healing. Those are things we are trying as much as possible to target for in the person when we are managing diverticulitis. So how do we manage dietary? Like we saw that this is a disease that is common to people who are having low fiber in their diet. We will look at moderately restricting fiber. Okay, in most cases when this happens, due to this inflammation, sometimes this fiber will be contraindicated. But then in other parts, we will indicate the fiber. So it depends on you how you're going to read your literature and how you're going to read your client. So you will see that at the end of the day, you will find ways in which after this person has healed, you can now indicate fiber into their diet. Then that is for the chronic cases. Then for the chronic, we are meaning long term. Okay. Then acute cases, when we talk of acute, we are talking about something that could be life-threatening, but it is going to be in a short period of time, or it is developing in a short period of time. And we are talking of a clear liquid diet progressing to slow residue diet, to a low residue diet. Low residue because we don't want any foods remaining therein. Excuse me. Yeah, so we finished the chronic, and we are also saying that for acute cases, use the clear liquid progressing to a very low liquid diet. And this really still almost the same. We are trying as much as possible to limit that insoluble fiber from being taken in. And here we are trying as much as possible to also reduce the volume and the frequency of the bowel movements, because the more the residue there is in the stomach, the more the bowel movements. And it will be indicated in also other cases that will require this. And also, we are saying provide a high calorie diet, except in overweight cases. For cases that have overweight, still we won't indicate the high calorie diet. High calorie because at the end of the day, if we indicate high calorie for those clients who are already overweight, will get problems. Things to do with the hypertension could set in. Things to do with the diabetes could also set in. Then it will make management difficult, because you will see that at the end of the day, maybe when we get our assessments, we will pair up different conditions. Okay, you could have a diabetic client who is hypertensive. Okay, you could have a diabetic client who has liver cirrhosis or fatty liver, whatever, call it anything. You could have a client who is having the cancer, but then they are also having a different condition, maybe cancer and TB. You will see that there are different arrangements according to the nutritional needs that you can kind of customize for that particular client that you've got, because not all clients are going to come with one particular disease. I know most of you have been in health settings. You realize that you're not only managing one particular condition, but a number of conditions are there for you to manage. So when you are determining the energy needs, so the total energy expenditure is composed of three factors. Okay, yes, and I hope we pay a lot of attention here. We are saying that the total energy expenditure of any human being is composed of three factors. One, we are talking of the basal metabolic rate. Okay, and I hope we all remember. And we also said that thermic effect of the food and also the activities of daily living. Okay, yeah, remember what basal metabolic rate is. Do we? Okay, I hope I'm not speaking alone. Sometimes I be looking at the laptop and I'm thinking I'm alone. Hopefully you're there. When we talked of the basal metabolic rate, we said that this is the number of calories, okay, your body uses, or what your body needs when it is at rest, and it is performing those functions that do not require a lot of energy, things to do with the breathing, things to do with the circulation of the blood, things to do with maintaining the body temperature. And we're saying that it accounts for the largest proportion of your daily energy expenditure, because these are things we don't even actually know, okay, but then they consume our energy. So that is the total energy expenditure. Why we are saying body basal metabolic rate is really a factor. Then, for calculating the basal metabolic rate calculation formulas for men and for women are different. And the examples I think we'll see hopefully later on. And then when we talk of the thermic effect of food, Okay, also sometimes people call it thermogenesis, and usually this is the expenditure associated with the digestion, with the absorption, and the metabolism of food. Okay, yeah, that is the thermic effect of food. That is the energy expenditure associated with the digestion, with the absorption, and also the metabolism of food. And really, it represents the calories that are burnt down in this process, and also how you're going to be able to utilize these nutrients from the food we eat. Okay, it accounts for approximately people have valued 15 to 10 to 15% of our total daily energy requirement. Right. Really, these are very key, okay? Because you can see that the basal metabolic rate represents the baseline energy expenditure required. And also, we look at the thermic effect of food, which reflects that additional energy that you require to digest and metabolize the food at the end of the day. We will see these calculations later on in our other engagements. Hopefully, we can cover it there. And the activity factors. For activity lifestyle factors, we have that sedentary, mild, the moderate, the heavy, and also the extremely active categories of individuals. You realize that most of the people in this day and age do not want to exercise. People are finding easier ways. I'm not against the technology advancements where people are relying more on machines, because really, if people are not relying more on machines, then I wouldn't be also here to deliver this information to you people. But really, people are no longer doing those strenuous activities. There is always a robot, there is always a machine to crash. People who used to use these stones to mill these days don't need to mill by pressing just a switch. The milling machine starts rotating, which is all good. But really, as much as possible, let's try to exercise our bodies to improve the blood circulation. And the more the circulation, the more we prevent some diseases, the more we burn down excess fat and all those other things. Also, our activity or stress factors determine the level of physical activity. Okay, yeah. So for the sedentary, we are looking at the basal metabolic rate. Time was 1.2. Okay, and then for the light activity, we are looking at those light exercises over in 1 to 3 days. You're looking at basal metabolic rate multiplied by 1.375, and all those that you will go over. Okay, so what are the for the energy needs? For the energy needs are based on the activity factors. For a person who is overweight and is doing sedentary activity, we are looking at 20 to 25 kilocalories per kilogram body weight. And for a person who is overweight but is having moderate to physical intensity, this I think is a little challenging, because even when people talk about this physical activity measurement, you remember it was called erogenous or exogenous, something like that, that takes a physical activity of more than 1 hour to their categories, different categories. I think we shall be looking at them sometime, but we are really seeing that we are having different energy needs for people with those different lifestyles. So you could advise accordingly. For people who are overweight, they are overweight and they are living a sedentary life. When we talk of sedentary, really there is not a lot of energy expenditure. A person wakes up, they go sit in front of a laptop. When they sit in front of a laptop, they submit reports. The only exercise they can do is maybe move up a building, but even these days in the buildings there are elevators, so people really don't do any exercise at all. So what we are saying, for individuals who are a bit overweight, with 20 to 25, we recommend 20 to 25 kilocalories per kilogram body weight. And if we are doing moderate, we recommend 30 and 35, as you see. And for the normal, we are looking at, if you're normal and you're doing these normal day-to-day activities, we are looking at 30 kilocalories per kilogram body weight. And you remember how we distributed these calories amongst the different foods, that you're supposed to get 10% from fats and around 80 from the carbohydrate part. And also, we looked at a number of things when we were looking at why we do not rely on proteins only, and how challenging it would be if we're relying on fats only where ketone bodies would be produced, leading to ketoacidosis and all those other things. Okay, I think we can appreciate the slide further with those figures that you see. So now, friends, let's look at the hiatal hernia. Okay, and we are saying that hiatal hernia refers to an anatomical abnormality that in which the part of the stomach protruding is coming out. Okay, protrudes through the diaphragm into the chest. Okay, and we are saying this occurs. Uh, that is the sorry. We are saying the anatomy. This hiatal hernia is anatomic abnormality in which the part of the stomach protrudes the diaphragm into the chest. There is an outpoaching of a portion of the stomach in the chest through the esophageal hiatus of the diaphragm. We will see this later on. Hopefully, you did some. Is it physiology here or anatomy? One of the two. And really, this can happen when that opening is there, the hiatus in the diaphragm, where the esophagus passes and it becomes enlarged and weakened. And really, there have been found to be a different types where we have the sliding hiatal hernia and also the paraesophageal hiatal hernia, as you will see when you go and do some further reading on that. Yeah, I think this is what they call the GERD. Okay, yeah. Some people have valued it is the gastroesophageal reflux disease, something like that. Okay, and we are saying usually the stomach is completely below the diaphragm. Okay, but you remember that diaphragm, if you were drawing the lungs, the respiratory system in our elementary levels. So we are saying usually the stomach is completely below the diaphragm, and that sheet of muscle that separates the lungs and the chest from the abdomen is that. But in some people, the part of the stomach or the sphincter can slide up into the chest activity, and this is what we call the hiatal hernia. And we are saying it's quite common, but in some people it may cause the heartburn due to the reflux of the stomach acid. And we saw what the stomach acid is. Okay. So are we trying? If you can see, basing on my previous explanation, this is the stomach here, and we are seeing a little bit of a protruding of this stomach coming into this. This is how the normal is supposed to be like. And yeah, let me try as much as possible to zoom in. We shall zoom out later. Okay, I hope we can see a little bit clearly. So this is the extension of the hiatal hernia as we see, and this is the diaphragm line as we see. So we are saying right. So you're saying larger than the normal esophageal height hiatus. That's one of the causes, and also the opening of the diaphragm through the esophagus passes from the chest to the abdomen, like we had explained. And what are the signs and symptoms of this hiatal hernia? We are looking at discomfort after some heavy meals, and also stomach distension. Okay, and also the difficulty in breathing, lying down, bending, and all these. If they are reported, we start as much as possible to suspect this. And if we can't really ascertain this critically, we will try as much as possible to do the x-rays. That's why I say we can't work in isolation. We need to work with also other medical personnel, other people in the medical field. So with the dietary management, we are looking at the in acute phase, please provide the liquid diet that is less abrasive to the esophagus, okay, and also avoid those acidic foods such as the citric fruits. When you talk of the citric fruits, that's where the lemons fall, the lemons, the oranges, the tangerines, etc., and also the tomato products, coffee, carbonated beverages, alcohol, spices, and condiments, all of which will lower the esophageal sphincter or the valve according to the individual's tolerance. And also provide the low fat foods and also the small frequent meals so that we do not bombard or make the person go through pain when these foods are passing there. In most cases, when we are trying as much as possible to indicate our nutrition interventions to individuals, we usually talk of these small frequent meals. And why we talk of small frequent meals is at least someone has a leeway of saying, I will eat tomorrow or I will eat in the evening. And even if we have losses along the way with small frequent meals, we can always try as much as possible to cover our tracks. If we have losses due to diarrhea, if we have losses due to diarrhea, losses due to vomiting. Still, we have a leeway with these small frequent meals to cover up for those losses in calorie and also those losses in other nutrients. We are also saying timing of the evening meal is important. The patient should consume nothing except water for 3 hours before lying down because you realize there is some pain when the individual is trying to lie down. And also avoid or quit smoking as it triggers acid production. But this, I told you, even when we talk of you trying as much as possible to stop, the first word you can see from this slide is avoid or quit. Even when someone is trying as much as to avoid, still we take them step by step. You know, behavior change is a very hard issue to deal with. But when things get to this, then we try as much as possible to tell them how to quit the smoking and also the disadvantages of tobacco. What I accept with our generation right now, the generation of the millennials, people out there really understand that there are challenges associated with the tobacco smoking, the lung cancers, etc. And we are saying still elevate the head of the bed when the person is sleeping to avoid that discomfort and also avoid clothing that is tied in the abdominal area and also maintain an upright posture during and after eating and also reduce the weight if there is overweight. So diseases and disorders slash the gastric diseases here, most of these we could call them disorders really or conditions. We have the indigestion, the acute gastritis, the chronic gastritis, the dumping syndrome, which we looked at yesterday, and also we have the duodenal and the gastric ulcers. Really, these we have seen as from the start, and with for the people who are not here yesterday, when we talked of the dumping syndrome, we said this is a condition where the food moves too quickly from the stomach into the intestine, and when once this moves, it often happens after those surgeries. When we talked of the Roxanne Y bypass surgery or the gastric bypass, where when we are trying as much as possible to shorten the distance of the food that to shorten the distance that the food takes in the digestive system so that we try as much as possible to limit the absorption of other nutrients in the body. Really, that is what we talked of the dumping. And we say this could end up leading to malnutrition because the individual will not be getting. Earlier on, we are trying as much as possible to fight the overweight, but then if it is done still, we will get to a point when the individual is now malnourished, and also these other cases will occur, the heartburns and etc. Really, then when we talk of the indigestion, we are saying, or you could call it the dyspepsia. We are looking at the discomfort or pain in the upper abdomen. Okay, or what you could call any discomfort that is in the digestive tract, really in the upper abdomen, and it is caused by the gallbladder diseases, issues to do with the chronic appendicitis, the ulcer disease, stress, the rapid eating, poor mastication. When we talk of mastication, mastication is the process by which the teeth cut the food or munch the food. So mastication is that, and overindulgence and food allergies. So most people have suffered from this indigestion after large meals for some time. Okay. Yeah, and we are saying this can occur due to people who are consuming also those are spicy foods, and also people who are smoking. That's when we have a lot of people with these symptoms. We are looking at discomfort in the digestive tract, and also that feeling of fullness after eating, the early satiety, and the belching. Belching is that gas that comes out, and also the epigastric pain, which is the pain just immediately above the stomach, just below the chest. So, whenever possible, it is important to determine what the cause of this indigestion, or what you could call the dyspepsia, is. Okay, also people report of this flatulence, the heartburns, also the nausea, the bloating, and also those other kind of things. So, what are the nutrition implications in this? Okay, so what do we really want to do when we are faced with this? So, really, once this happens to you, in most cases, we are talking of inadequate food intake. Okay, yeah. And how could we help ourselves with this? We are saying that individuals who are having indigestion may find relief by making specific dietary changes, okay, and avoiding those foods that really try as much as possible to trigger and also worsen that situation. And also, people are talking of the meal timing and also the dietary management. We find ways in which we can do that. Try as much as possible to provide a well balanced diet. When we talk about well balanced diet, what we mean, the different categories of the nutrients that we really require in that, and also avoid poor rapid eating. This usually happens in schools. Whenever you hear the bell, you hear the sound of the bell, you're trying as much as possible to get into the next class, and also avoid the overindulgence. And also, we are saying take plenty of water. Also, we are saying that there could be an association between this and also weight management. Okay, yeah. So you consuming those high calories and high foods, high fat foods may really lead to you becoming obese and also leading to this indigestion. Emotional well-being is also key when we're talking about this. Emotional well-being, where we are saying that anxieties could also exacerbate. So practice those stress reduction techniques, the deep breathings, the medications, and the yogas. Like some people try to do, though some people claim they are satanic, but I don't know a lot about that. So you will go and do your research. So, friends, let's look at the most common one when we talk of these gastrointestinal disorders. In most cases, we talk of the peptic ulcers. Oh, whoever will come to you will come and tell you, Musao, I have peptic ulcers. Musao, I have this. Musao, I have this. In most cases, the most clients you get will be clients who are suffering from ulcers, maybe peptic or duodenal, whatever the case is. And we are saying this is a general term given to uneroded mucosal lesion. Okay, yeah, that lining of the inner gastrointestinal tract, wherever it is raised, that is what we call an ulcer. But really, here the positioning is in most cases around the gastrointestinal from the stomach downwards. And the areas affected include the lower portion of the esophagus and also the stomach and the first part of the duodenum. And the bacteria that is responsible for this is usually the Helicobacter pylori, which causes this. And the second leading cause is the use of these non-steroid or anti-inflammatory drugs that may damage the stomach lining. However, these could irritate the stomach lining, however much given, leading to the indigestions, the heartburns that we saw, and also the stomach pains, the nausea. Some people have said that these can also lead to cardiovascular diseases, bleedings, and also other allergic reactions. The gastric ulcers normally occur in 45 to 60, and also the duodenal ulcers occur in ages 20 to 30, so no one is actually safe. So the exact cause really is not known, however much we've talked of the Helicobacter pylori, but we see that it is multicausal and there is also a genetic association. For people with a family history of these peptic ulcers, Really, I'm not saying that I'm the angel of doom here, but really there are chances that you will also develop this, and also the infectious microorganisms that we've seen, and also these the non-steroid anti-inflammatory drugs such as the aspirin, the brufen, the diclofenac, which people use as pain reliefs. The paracetamol dramatically increase the risk of these ulcers, and also the emotional stress, okay, especially prolonged anxiety, can aggravate ulcers by stimulating the vagus nerve and the release of more acetylcholine, and also decrease the acid secretion and hypermobility. Okay, so what are the symptoms of these, what you could call the symptoms of gastric ulcers? We have anorexia. We remember what anorexia was, whereby people really don't want to eat the food, and even when they do the intake, they try as much as possible to regurgitate it out so that it leaves. Okay, depending on which anorexia the person is suffering from. Also, we are having nausea and also vomiting and also weight loss. But really, things to do with abdominal pains also won't leave you, and also things to do with the bleedings in there. And also, we are saying that some people who have these gastric ulcers may not experience any signs and symptoms. So it is usually asymptomatic when it is in its earliest stages. Alright, for the duodenal ulcer, so there is an epigastric pain appearing at the as deep hunger contractions 2 to 3 hours after meals, and the pain is due to the action of the neutralized acid or exposure of the nerve fibers. Okay, so there is good appetite, there is constipation, and also there is weight gain. When we talk of hemorrhoids due to bleeding, okay, the duodenal ulcers, and also perforation of the mucosal lining opening through that gastric or the duodenal wall, and also the penetration into the adjacent tissues, organs. Also, obstructions can be reported, such as the pyloric stenosis and gastric outlet. What are the nutrition implications in peptic ulcers? What could this lead to? With the hemorrhage, we saw it will lead to anemia, and also the altered food intake at the end of the day, since there will be loss in appetite and all that. So, why do we aim for under nutrition management? We aim at reducing and neutralizing the stomach acid secretion so as to reduce the pain, and also maintaining the acid resistance of gastrointestinal epithelial tissues. And also trying as much as possible to limit the patient's discomfort, and also making them relieve that pain. I hope you sometimes have you've seen your friends who are suffering with ulcers. Whenever these sharp pains come, these people are very irritable. They can even slap you when you talk to them, when you come closer to them, because of the pain that they are feeling. And also, we try as much as possible to provide that continuous neutralization of the gastric acid. We promote healing and also reduce the irritation of the GIT. And we know that fiber is one of the irritants of the GIT, the insoluble fiber basically. So we try as much as possible to limit this and also restore the good nutritional status, and to reduce from that mechanical and thermal and chemical irritation of the gastric mucosa. So patients with peptic ulcers disease should at least eat 3 regular meals daily. Okay, when you talk of meals, we are talking of lunch, breakfast, and supper. Okay, it's breakfast, lunch, and supper in their order. However, people try as much as possible to make snacks meals, but snacks are not meals. When we talk of a meal, a classification, a good example of a meal is a serving containing two or more dishes. That's what we can say is a meal. An accompaniment, okay? Yeah. Really, when we talk of a protein and a carbohydrate, then we could classify that as a meal. Protein, carbohydrate, and a vitamin, a fruit or a vegetable, we could that gives us some nutrients, the micronutrients, the vitamins and the minerals. Still, we could claim that to be a meal. And we're also saying eat small meals to avoid stomach distension, avoid eating rapidly, and also use in moderation easily digested fats like the whole milk, the egg yolk, the cream and butter, etc., and avoid drinking excess coffee and alcohol. Also, try as much as possible to cut down or quit the smoking. So, also use large amounts of aspirin and other these non-steroidal uh, sorry. I'm saying try as much as possible to use these non-steroidal anti-inflammatory drugs or other drugs known to damage the stomach lining. Okay, so we try as much as possible to avoid using these. Okay, for the women who are going into menstruation, who usually can't do without their diclofenac, try as much as possible to limit these, and also try to tell your clients whenever they come suffering with these ulcers, whenever they come reporting the ulcers, that excessive use of these when someone is experiencing pain should be stopped. And also avoid foods that cause any discomfort because these discomforts are relative. Really, nutrition can try to tell you that matoke will lead to increasing in the ulcers, but then at the end of the day, when someone eats it, still they will be doing better. Or if someone takes la cassava that you contraindicated, the person will be feeling well. So try as much as possible to understand how the different foods treat the individual that you're working on. And also eat the meals in a relaxed atmosphere as possible so that you can eat it slowly. And also take these antacids 1 or 3 hours after the meals before bedtime. Remember what our antacids do, they stop these gastric refluxes from happening. So once they stop, that means we won't be feeling pain in those ulcers where now the mucosal lining has been removed. Finally, we are saying you try a bland diet. Here we are trying as much as possible to moderate in fiber and connective tissues and also little or no condiments or spices except for salt in small amounts, and also avoid and eliminate those highly acid foods like I've said, and also foods should be simply prepared, not a lot of garnishes and all those other things that are therein. So today, friends, we've been looking at the different conditions that are really in there from the ulcerative colitis, the diverticulitis. We've been looking at the hiatohernias and how we could use the food and how we could manage them nutritionally and what our aim is. You will realize that in the different disorders we are looking at, our major aim is to restore a normal nutritional status. Because if a person is coming, whether they are overweight, whether they are underweight, we are trying as much as possible to bring them back to the normal nutritional status. Unless there is anything left. This is we are at the end of our today's engagement. Maybe we meet tomorrow. Do you have anything? Yes, James.
Yeah, good evening, sir.
Good evening, James.
Thank you very much. It is a very enjoyable lecture this particular moment. I would like to ask also out of our lecture, but it's also a nutrition concern question.
Mm,
It's about also the management of the pregnant mothers
yeah.
uh, in concern about the avoidance of food like taking a coffee and
Mm,
the red tea. So sometimes there is some confusion from me that some Facebook they don't give me the clue well, but as my lecturer, so you will also give me more about it because some textbook they say that it is also slowing down the hemoglobin of the pregnant mothers, which can also
mm,
result into the anemia at the end of the day.
mm.
Some books, but they say the taking maybe a copy also is one of the stimulating of the body tissues. And I don't know which one should be real.
Okay. Thank you very much for that question. Really, though you said it is out of our lecture, but if I'm to remember very well that there should be moderate intake of coffee, okay, if someone is pregnant, because this coffee contains caffeine, and when there is high caffeine intake during pregnancies, there could be issues to do with miscarriages and preterm births, okay, that could happen. That is some recommendation I read somewhere while I was still doing. Uh, 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 my bachelor's. And also, they said that when someone takes in coffee, coffee has ways in which it crosses the placenta and it will reach the uterus. And once it reaches the uterus or the fetus, let's say where the fetus is, this can have stimulating effects and also can interfere with the fetal development. So, really, it is essential for most of these pregnant individuals to consider not only coffee but also those other sources of caffeine and also other things such as the teas, the sodas, the energy drinks, the chocolates, those things. But really, that is as much as I know according to your question. I hope I've answered you. Yes, James, I hope I've answered your